Hi everybody, this PowerPoint video goes over the introduction to pharmacology. So throughout the video we are going to cover a little bit about pharmacokinetics and pharmacodynamics. So first we're going to look at the pharmacology of systemic medications. So essentially we're talking about medications that are traveling throughout the general circulatory system. And there's different routes of administration that we do use for systemic medications. So administration, or basically we can refer to it as ingestion of the medication. So first there's enteral. Enteral, when we say enteral, it basically means that is through the GI tract, the gastrointestinal tract. Obviously they can be taken orally by mouth or a rectal suppository. And the rectal suppository also can have systemic effects as well. For example, sometimes we will use rectal suppositories for anti-nausea. We also give Tylenol through that measure, through the rectal suppository, and they will have systemic effects on the body. The next route is a topical route. Topical can also have systemic effects. First we have inhalers, which is through the respiratory tract, and then we also have creams and lotions, or transdermal patches. For instance, a transdermal patch could be like an oral, not an oral, it would be a contraceptive patch. So with this, the contraceptive patch is producing systemic effects. Same thing with like a nitro patch. We also use nitroglycerin patches affecting the cardiovascular system. And then last, we also have parenteral administration. So with this, it could be considered the most common that you most commonly will hear is either IV, which is intravenous, or injection. And that could be subcutaneous or IM. And also that's included in the parenteral is the sublingual or the buccal administration. And those are basically placed under the tongue, and it is absorbed through the mucosa, but this goes directly into the circulatory system. So this isn't going through the stomach, to get dissolved and then being absorbed. So they do not have that first pass effect, and you'll hear the word first pass effect with oral medications. And I'll go through that in just a moment. So the one important thing to realize is that with these different routes of administration, a lot of times it determines the onset of action. And also with these different routes of administration, the concentration of the drug is different. For instance, if you were to give a medication by mouth and it's done enterally through the GI tract, the drug goes under dissolution, it gets absorbed through the intestine and then it goes to the liver. So through that process, the amount of drug that was originally given is actually reduced. Versus if you were to give a medication IV. The medication that you're giving IV, the dosing of it would probably be, not always, but most of the time is a lot less than what the dose would be if you were giving it PO or by mouth. So when I was talking about the first pass effect, this is with oral medications. This is when they go through the GI tract, and then they basically end up in the stomach. They have to be broken down, and sometimes when we say it's broken down, it can be referred to as dissolution. With dissolution, the drug is broken down into a form that can be absorbed by the body. And then we also have biotransformation, which occurs in the liver. This is where the drug is broken down into a different form of metabolites, and then these metabolites are what is actually, crosses over to the bloodstream. So as you can see, when there is an oral medication given, there's a few steps here that we call the first pass effect that actually will, reduce the drug down into different metabolites. So when we have metabolites, some of them travel to the kidney to be excreted or eliminated, and some make it to the tissue, to the receptor, where the treatment for the condition begins. So the drug or its metabolite will work at different sites. So in terms of absorption, what factors would affect absorption? Sometimes it could be, it could start all the way back from the GI tract, and the GI tract, GI motility kind of gets things moving. It could be too much or too quick, where the drug is, sitting there too long, or if there's hypermotility, then it's moving through too quickly and they're not absorbing enough of it. Other factors that can affect it too, if if there's issues with their kidneys or anything with their circulatory system. So once these metabolites are traveling through, and like I was saying, they end up at the tissue site or the cell. And then on these cells, they have receptors. And receptors essentially signal the cells to do something. They want them to exert an effect. This may be making a hormone or initiating a physiologic action. So a receptor, this is a little general overview. A receptor is any functional macromolecule in the cell to which a drug binds to produce its effects. Technically, receptors can include enzymes, ribosomes, and tubulin. So there's receptors on all sorts of different cells, and that's how we find drugs that will actually work on, our normal physiologic system. Drugs aren't actually changing anything. They're actually working on what our body normally does. It's not changing it. It's just kind of either facilitating it to do it more, less, or stopping it, or so on. So the receptor is generally reserved to refer to the body's own receptors for hormones, neurotransmitters, and other regulatory molecules. So important properties of receptors. Receptors are normally points of control for a physiologic process. That's what I was just basically saying. So these receptors normally control the process that's going on in that cell. Under physiologic conditions, receptor functions regulated by molecules supplied by the body. So drugs only can mimic or block the body's own regulatory molecules. So that's what I was saying. It's basically working on your own physiologic system. Drugs cannot give cells new functions. Receptors and selectivity of drug action. So the more selective a drug is, the fewer side effects it will produce. Meaning, the more selective it is to a certain receptor, the fewer side effects it produces, because it will only go to certain receptors, if that makes sense. So receptors are what makes selectivity possible. And selectivity, basically what I mean by that is it's targeting specific areas, only certain areas, because you don't want it turning on multiple areas. That's when side effects occur. Each type of receptor participates in the regulation of just a few processes. So this is how we get selectivity with drugs. Now we do have drugs that do not involve receptors. So there's some simple physical or chemical interaction with other small molecules. And here's some examples of receptorless drugs and acids. It just basically neutralizes the stomach acidity. Antiseptics, it just locally will kill the bacteria. Saline laxatives, that's like an osmotic laxative. And then chelating agents, it kind of binds to certain things, the certain molecules. So these do not work with receptors. So it's not that every drug uses receptors, but there's a good majority of drugs that are developed to work on receptors. So drugs, when we're referring to them, sometimes when they're working on these receptors, we can refer to them as an agonist or an antagonist. So the drug will bind to the receptor to produce a therapeutic effect. They tell this receptor to basically go and do it. They want it to go ahead and continue on to start the process. So with this, the drug works with the receptor. It binds to the receptor and produces a therapeutic effect. It's important to realize that most drugs essentially work through activation of our body's own normal mechanisms. It's not changing anything. It's basically turning it on or speeding it up. And that's what an agonist essentially does. Then we also have antagonists. These essentially bind to the receptor and block its action. They prevent the cell from doing something specific. So they essentially say, don't do it, and to stop it. Like they want to stop the action of the normal chemical reaction at the receptor. And they're basically preventing the cell or wherever it's working, whatever physiologic system or cell that it's working on, it'll tell it to stop doing its normal activity. So it's not changing anything. It's working on our own physiologic process that we have. So here's two other images depicting kind of what I was just talking about, agonist and antagonist at receptor sites. Over on the left side, you can see the natural ligand, and then we have agonist and antagonist. So when you look at the second one, the agonist, it binds and tells it to turn on. So they're looking at it if you look at it, they're just showing, like another mechanism going into the keyhole saying turn on. If you look at the antagonist, you can see that they also have like the leaf into the keyhole, and basically it's blocking its activity. So it's not allowing it to be turned on. And then the one below, in the other chart below, the other picture where they have the green, the blue, and the orange drugs, they have the before drugs. So they show natural chemicals that are working at the receptor sites, and that's producing normal cellular activity. So the first one where it says before drug, it'll say natural chemical and receptor site. That's the normal physiologic process going on. If you look at the middle one where it says agonist drug, you have the natural chemical there, but you also have the agonist drug. So this is enhancing the cellular activity. It's turning it on and stimulating it to work further. If you look at the third one where it says antagonist drug, you have a natural chemical, which is the green part, the receptor site, and the drug is actually, the antagonist drug is actually blocking the receptor site. So it's blocking the normal natural chemical process going on. So that's basically how you can understand agonists and antagonists. You'll revisit agonists and antagonists throughout the semester. What I'm trying to get across is that a lot of drugs work on our normal most of them work on our normal physiologic system. Same thing with neuropharmacology. A lot of it is all done through our normal parasympathetic and sympathetic nervous system. I'm not trying to go off track here, but I just want to make it, apparent that a lot of these drugs work on our body system. It's just kind of turning them on, speeding them up, slowing them down, blocking them to produce the effects that we want. So that's kind of, you'll see agonists, like a beta agonist or, alpha adrenergic agonists. Like those will come across when we kind of go through different drugs. So if you understand this, I think it'll help you when you go further along into the medication classifications. Next, we have elimination, and it's commonly through the kidneys. So what physiologic processes can affect elimination? When you read the part on, drug therapy throughout the lifespan, you can see that in the neonate, their liver and kidneys are immature. So the clearance of drugs, are not the greatest, or metabolism of the drugs aren't the greatest. So, dosing with them is usually commonly lower. If they can't effectively get rid of it, then they're at risk for more toxicity or more side effects from it. And the same thing with the elderly. Usually as time goes on, there's a few factors in there that, that can cause them to need a reduced dose as well. If their kidneys aren't functioning great, that's another thing. Same thing as with the neonate. They aren't clearing the drug as quickly. We usually will have to reduce it with that as well. And in terms of reduced elimination, what can it cause? It can cause toxicity. Toxicity meaning concentration of the medication higher than what we would want it to be at. What if they're not administered through the enteral route? If we go with the topical route, the IM route, or subcutaneous, the topical and IM and the subcutaneous, they all have to be absorbed through the outer layers of the tissue. They have to make it through the tissue, the fat, etc., and then be absorbed into the capillary system. IV medications are very quick acting because they're directed directly into the circulatory system. So they aren't undergoing any dissolution or absorption like that. They're directly into the IV, the intravenous source, and they're immediately working as they make it through the heart, the lungs, and the heart, and so on. So when I would talk about implications over on the right side, biotransformation occurs in the liver. Can happen sometimes with the other drugs when they're given through different routes, but it's more common with the oral drugs. Elimination is the same. They're usually eliminated through the kidneys. The difference here, and the biggest thing that's most important to understand, is the speed of absorption when you're looking at these different routes. So if you want something to get in fast, quick, like let's say epi or something like that, IV dosing is number one. Or if you have, if you're giving a pain medicine to a patient in the hospital, a lot of times if it's severe, you want to get it in right away, quick, you do IV. IM and topical, those can take a little bit longer. And oral, that's unfortunately usually a little bit longer as well, but that's usually the most common. Now we're going to look at distribution. So this is transport of the drug through the bloodstream. So this is once the drugs are actually in the bloodstream, they need to be transported. So we have different factors here that affect transportation and the transportation or distribution of the medication. So first we look at protein binding. Protein binding, it basically makes the drug not available to treat the body. And some drugs are very susceptible to this. And then there's other drugs that actually, if you give them two different drugs, they compete for protein binding. And that's kind of another factor too that we'll go into a little bit later. But protein binding basically ties up the drug. It keeps it tied up so that it cannot be biologically active. Another factor that affects distribution is lipid solubility. Cell membranes have a high concentration of lipids. So drugs that are highly lipid soluble, they pass easier through the cell membranes. And that's another factor too that will affect the blood-brain barrier, which basically is the barrier to your CNS. So if they can pass, this is kind of going off a little bit, but if they can pass through the brain barrier, that's when they can get the CNS effects. Like that's when you get the drowsiness and more of the neurologic symptoms or effects from it. Another thing that affects distribution is your circulation. Obviously, if your blood volume is low, you don't have a good flow of the blood to get it to the tissues. Vascular resistance is kind of the same factor here. If your resistance is really high, meaning like if your blood vessels are constricted, the circulation is reduced because it's trying to fight against this high pressure system, and it's not making it to the tissues or the areas where it needs to be as quickly. Cardiac output's another thing. These are all kind of the same thing, it's just different forms of it. Cardiac output, which is how well your heart is pumping. So your cardiac output, if that's reduced, the travel or the distribution of the medication is going to be lower. So those are all factors that can affect distribution. So this is just basically a little chart of kind of what we went through. So if you start over on the left side where it says enteral, the enteral, which is the PO, the rectal, it can be anything that has to travel through the GI tract. And that basically points down to the GI tract. So anything enteral goes to the GI system and then ends up in the bloodstream. Same thing with topical, it goes to the bloodstream. Parental, it goes to the bloodstream. It's just a matter of how long it takes to get there. Once it gets to the bloodstream, the medication either goes to the target tissue receptor sites, and that's where it will produce its therapeutic effect, or it goes to the kidney. So you may have some that go to the target tissue, and you may have some that goes to the kidneys. And once it goes to the kidneys, it's excreted for elimination. And then you also have from the bloodstream to storage. So sometimes drugs are actually stored in body tissues or fat. So some are actually, that's another area where it would go to. So this is just a run through of basically everything that I went over before. Next, we're going to talk a little bit about adverse reactions and side effects. So there's a little bit of a difference between adverse reactions and side effects. Adverse reaction is any undesirable effect, and this may include the more minor side effects. So basically, as a nurse, we're responsible for determining if a desired effect occurs, and we are also responsible for monitoring for any adverse effects. If we recognize, these side effects early, the outcome is usually much better. And the same thing with therapeutic effects. If we're following it closely, if it's not working, we can, determine a different solution for it, or if it's causing problems, we have to, stop it or change it. So, the nurse is usually first line in monitoring this. Another important thing, too, when looking at side effects and the side effect profile, every drug has side effects, unfortunately. The biggest thing is you have to weigh the risk-benefit ratio between treatment and the onset of side effects. If it's something that is, life-threatening, obviously you have to treat it, and there may be side effects, but you've got to kind of weigh the risk-benefit ratio there. Next is therapeutic concentration. And this is just kind of talking to, it kind of branches off of adverse reactions. So with therapeutic concentration, we're looking at the concentration of a drug. So even if there is some drug in the system, it doesn't necessarily mean that it's therapeutic. It can be too high or too low. If it's too low, it's not enough to work, and if it's too high, that's when you can develop toxicity. So you may see this dose curve in the pharmacology book, and it looks at the concentration and it looks at time. And this basically is just all this is to try to show you where a therapeutic range is and looking at the onset action of the drug. So if you look over down at the onset time, so basically when you go up onto the curve, it starts from the time they take your drug to the onset of a therapeutic response. And that's when it's finally working at that point. So when you go up to that one top, that's when they actually, where it says MEC, that's actually where you'll start to notice therapeutic benefits. Now, you also see the duration of action at the top. It'll show the length of time that the drug is actually therapeutic at that point. And then you also see in between the MTC and the MEC is the therapeutic range. So this is the range where the drug will be effective. If you're going too high, that's when you're getting to the toxic levels. And then if you're going too low below the therapeutic range, they're not getting enough for it to produce an effect. And then where you see the peak up there, that's basically the peak level of the drug. I did another one over here. It's basically the same chart, but it shows a few more things, with labeling on it with the peak effect, the duration of action, and therapeutic window, which we'll talk about too. Let's go back to the duration of action. So when I was saying it before, the drug remains active in the body as long as its concentration remains above the therapeutic level in the bloodstream. Now, a therapeutic index, so even though the drug may be at a therapeutic concentration, like I was saying, it doesn't mean it's safe. It could be at a toxic level. So drugs with a really small therapeutic window or therapeutic index, they typically require serum drug levels. There's certain drugs that we will actually have to monitor with serum, meaning blood work, to make sure that they're not above it in a toxic area or below it, where it's not being treated enough. So with a small therapeutic window, just picture up here if you're looking at the chart, if it was narrow, it's such a tiny little range of where it's toxic and not working that we actually will have to monitor the drug. And there's certain things like digoxin that we do this with. Vancomycin sometimes too. They'll do peaks and troughs with it too, just to kind of see where we're running with it. The larger, the higher the therapeutic index, the safer the drug. The smaller, the lower therapeutic index, the less safe the drug is. Let's talk a little bit about a half-life. The half-life is defined as the time required for the amount of drug in the body to decrease by 50%. So it basically will measure the concentration of the drug for it to be half out of the system. So half of the amount that you started with will be gone. And it's usually with a time factor. When you say like one half-life, that would be a 50% decrease. So basically, this actually will determine our dosing interval. So if the half-life is longer, it's usually dosed less frequently. If the half-life is short, it's something that has to be dosed more frequently. Typically with a half-life, it takes usually 4 to 5 half-lives for a drug to plateau in the blood. And the same thing with elimination. It usually takes 4 to 5 half-lives for the drug to be completely eliminated from the body system. So the half-life is just a way to look at how long the drug stays into the system.